So the PRU, or the Physician Response Unit, is made up of a number of very good-looking doctors, of which I'm not one of them, and we are a combined team with a member of the ambulance service working on a big red car. This is a new red car that we're going to have. You might see them out the front of the hospital that say Advanced Trauma Team on, but this is something called the Physician Response Unit, and although it's very important to London's Air Ambulance as a medical resource, it is different and unique from the trauma team on the helicopter, which we'll talk about. We do respond to 999 calls, and we are dispatched as any ambulance is dispatched through a call centre based in Bromley on Bow. This is the kit we carry in the boot of our car, which looks a bit of a mess when it's lined up there, but believe me, it's very well organised, and we know exactly what is where, and we can provide a lot of interventions both for low and high acuity calls, and some of that kit we're going to talk about as we go forward. The PRU, though, it's been around a long time, and you've been involved since the start, David, haven't you, or very near the start?
It's like Parkinson's, hasn't it, been introduced? I've actually been with PRU since, more or less since it started, so about 17 years, and it's gone through a number of iterations. This was actually the first car that we had, and it has to be said that really when we first started it was as a primary response unit, so or immediate response unit, and so we were going to mostly cardiac arrests, but there was this two sides to it where we were trying to keep people at home, but then the idea was that we would have some trauma, some intervention along those lines. And it was seen very much as an exciting and high-quality brand of emergency medicine, and it was a real opportunity to give people to go out on the roads and do this in a pre-hospital setting. It's become increasingly exciting as it's gone by, as years have gone by, and the next one. And this was, I think it's been now. This is the last time we came and presented to you, so hopefully you'll have us back sooner than this the next time around.
So yeah, a long time. Hopefully it won't be another 16, 17 years till we're back speaking at the medical grand round. But this is a paper based in 2006, which is a feasibility study with some pretty well-known authors on it. And it talked about a feasibility study for actually providing a physician response unit in North East London. And actually, if we look at exactly what that was, it hasn't changed a huge amount, although some of the calls have changed. And actually, when someone calls 999, this is directly listed out of this paper, you speak to a call taker, that call then gets triaged, an emergency medical dispatcher would dispatch an ambulance crew. That ambulance crew would more often than not bring that patient to hospital. They would go through a whole barrage of booking in A&E, seeing a triage nurse, you'd see the area nurse in 2A or majors, you'd then get to see a senior house officer, and then finally you'll get to see a senior decision maker quite a long way after the time you've called 999. What the PRU was aiming to do was front load that senior decision making at the start of that patient's journey and actually changing the direction for some of those patients. Hasn't changed too much in the last few years, although it's changed with respect to NHS 111 providing the London Ambulance Service with a number of calls, of which the Physician Response Unit does pick up a number, which we'll talk about in a bit. But the actual model within the ED hasn't really changed that much, although we do have more senior people at the front door in EA now, changing the decision making, get patients having the appropriate investigations earlier in their journey.
So the cars have changed, the service has changed with it. So it's not a new service. It is becoming more interesting, though, from the primary care point of view. So what we've become clear about is that we've recognised that the effectiveness of being able to take a physician it's basically medicine 101. You're taking a good history in an environment where you can get enough details, enter into a relationship with a patient on their home territory in order to keep them at home. And this has been extremely rewarding on all fronts. It's been known as the coolest car in London that saves lives, but I think that, as I said, we've sort of moved away from that to recognising that there is a very much a real working model here for having quite a dramatic impact on what ED can deal with, and saving ED from these patients coming in the first place.
Yeah, and I think it's fair to say that actually when the PRU was going through, you might have heard it known as a call card if you know anything about the history of the PRU, it was providing a lot of quality cardiac arrest management in the community. And luckily that's now available across London now through the advanced paramedic practitioners, which pick up the vast majority of the proper cardiac arrests happening every day on the streets of London. So although we still go to some high acuity calls, we go to a lot less, don't we?
Yeah, that's right. So, as you know, Sir Professor Kehoe, Sir Professor Kehoe, with his Urgent Emergency Care Review 2013, made a huge amount about the call really to deliver more care appropriately in the patient's home environment, and that's basically what we're doing. It feels like it's interesting because really this is what general practice has always been about. The traditional general practitioner would do their own home visits. They would expect to see emergencies. We all have seen the changes that have occurred in primary care. Primary care is under a lot of pressure at the moment. And in order to make this work, in order for his vision to actually come to fruition, we need to not reinvent general practice, but we need to be able to take those skills in a more appropriate way. And these are higher acuity patients. They are patients that it's not necessarily ones that GPs would have felt comfortable with doing. But we are seeing at the moment that there has been a bit of a step back in primary care in some parts of some boroughs, where as soon as an emergency comes in, then just dial 999. Now, these are perfect patients for us. Personally, as a GP of 30 years plus, I think these are patients that actually primary care could manage. But you have to realise primary care has come under massive pressure in recent years. And so the PRU has been instrumental in trying to grab that territory back, if you like.
Yeah, and when we link that vision up with that NHS England clearly has and is moving very quickly towards, we link that to the London Ambulance Service and what they're trying to do with respect to their moving forward to 2020, and what the people of London are going to expect is that the London Ambulance Service wants to have shared referral guidelines. LAS clinicians can't refer really anywhere at the moment. They want local priorities and improved urgent and emergency care solutions in partnership with our clinical commissioning colleagues. And actually they want to redesign the scope of practice for London paramedics and developing the clinical capabilities to reduce the need for conveyance. And we'll talk about conveyance rates in a minute, but people that call 999, about 70 to 75% of them end up coming into hospital. And we'll talk about actually what we do is turn that completely on its head and leave that percentage at home. So we'll touch on that in a minute. But we need to be in line with one of our key stakeholders, London Ambulance Service. The other stakeholders we work closely with, we'll talk about in a second. Sorry, David.
No, I think it's just that we were having a talk just before this presentation up on HEMS, and it is interesting how, because of government policy and change, various things, we tend to still be working in silos. So as we go through the rest of the slides, what I'd like you to do is to look at how we're trying to break down the barriers between these silos, and that's where we think the win is, both financially and in terms of patient care.
So because of this background that we've talking about, there was a case you needed a new identity, and there was a huge void for it to fill, and that was because for a few reasons. But one of the big things around the case for change is with clinical workforce. So we had a workforce, and we have emergency medicine having a bit of a recruitment crisis. The PRU enabled emergency medicine registrars to go and do what they do day in, day out, but out in the local community to understand the places we work in. The impact of the PRU was potentially huge if we think about going to lower acuity calls, and actually that's why our caseload has swung slightly, which we'll talk about. The system as a whole, though, it provided an opportunity for staff retention and recruitment, and it also allowed us to be completely innovative about the way that we deal with patient care. And like David was saying, breaking down some pretty massive barriers and some huge postcode lotteries that exist when we're trying to work out there in the community. So it's quite interesting.
So there was a big change as I said, the PRU had been running already for about 17 years, but there was a need to move it on. It was doing an 8-hour day, 5 days a week. We saw the potential for delivering more care instead of an ED in the community, so we expanded the service considerably. Its operational hours went from 8 to 8, so 12 hours a day, 7 days a week, 365 days a year. And then there was the appointment of 4 PRU fellows. This has been hugely successful, and then replacing the paramedic crew with emergency ambulance crew crews. There was something else I was going to mention about that, but no, you carry on.
That's right. I was just going to say at this point, it's worth just highlighting at the top of these slides, we have different logos. And we've talked about our involvement with London Ambulance Service. They dispatch us. They give the 999 jobs to us, and they provide the clinician which we work amongst. We have London's Air Ambulance, which is the PRU is part of London's Air Ambulance, and it's part of a key part of their strategy going forward. We sit within Bart's Health, and we are employees of Bart's Health, and the governance comes from that and LAA. And then the pilot that we're talking about here was due to funding from Tower Hamlets Together, which we will talk about in a minute. The fellowship that I'm on at the moment is for higher A&E trainees, so all SC3+, and we have a split job plan between the physician response unit, 40-45% ED, 40-45%, about 10% admin time, and to do some research and presentations at various conferences as well. What's unique for me is that we had some protected time, and some of my ED time is counting towards my training, so it's good for me as well. But we changed from becoming emergency medicine registrars to really becoming champions of emergency medicine out there in the community, and I think that for me was something that I completely underestimated, and really, really important to understand the situations and the challenges of the environment we all work in. We sit in this nice tower and we have amazing resources around us, but actually the reality of where a lot of our patients are living is very, very different. And I think it's been really eye-opening for me to learn personally about some of that and providing emergency medicine in the community.
I think it's also worth pointing out that up until now there hasn't been a joint training role. Or you either went into primary care or you went into hospital medicine, emergency medicine, etc. And I think throughout the time that I've been in A&E, I've often had SHOs, F2s coming up to me and saying, how can we do both? Because I've worked in A&E for quite some years as well. And I think this has provided a really exciting opportunity to combine the two. We've yet to see the colleges fully come together, but we're already doing some joint training. PRU embodies that direction of travel.
So I think it's so it's quite an exciting thing that we're involved with on 12-month fellowships. Well, as David already said, we have emergency ambulance crews with us, and they are technician based. You might have heard them called technicians in the past. In London, they are now called emergency ambulance crews, from a terminology point of view. But it gives them development opportunities to come and work alongside a doctor and have proper clinical discussions and learn from every case and have time to debrief every case to a lot of detail. But we, as emergency medicine doctors, are not used to working in the pre-hospital environment. Whereas providers, we can be put in some pretty vulnerable situations and pretty dangerous situations sometimes, and actually our colleagues from London Ambulance Service not only keep us safe, they're the absolute experts when it comes to managing scenes and getting patients out of tall buildings when they're in cardiac arrest and all sorts of very complex things that we don't as hospital clinicians think about because they come packaged on a trolley. But there's a lot of work to happen before you get to that point, which we learn from these guys, which is really good to do. With respect to the PRU, this is not probably a very good colour of slide, so apologies for that. But on the left-hand side, you can see the physician response unit. PRU is dispatched from Ambulance Service Operations Centre, Emergency Operations Centre, based in Bow. London has one in Bow and one in Waterloo that manages all 999 calls within London. We go to jobs in 3 different ways, and they're listed here. So we go as a primary response to a 999 call, so we will be dispatched as the only resource in London going to a job, and they tend to be lower acuity calls that we can turn around and prevent an ambulance conveying into A&E, the A&E and then admission to hospital. We also go as a crew request. So a lot of our crews that we work with in the community we get to know really well, especially in and around Tower Hamlets and the Royal London. So they get to know actually what we can do, and actually if a patient just needs some simple blood tests or some suturing or a catheter change, some simple stuff, or some more simple or some more complex, really complex medical case management for patients that should probably stay in the community anyway, we can go as a crew request and try and facilitate their care. And then we also work completely like this with the rapid response team here, and we are often sent out by the rapid response nurses to go and see patients that are not quite right, that are on community pathways that we want to try and keep their community care going rather than bouncing them back into A&E. So we pick up quite a bit of work from our RT colleagues, and we work really closely with them. We then go and see the patient, depending on what category. Most of the time we go on blue lights to these calls as they are 999 emergency calls. We will go and do a clinical assessment as you would in any other environment. You would do the appropriate investigations, which we'll talk about what we carry, and then the therapy. But the difference is we're doing it in the location they've called 999 in. So we're not doing it in a cubicle, in a sterile environment. We're actually doing it in their own home or their office or wherever it may be. And then once we've finished with that patient, we've arranged appropriate follow-up, or we've arranged, in some cases, speciality direct admission to a hospital, then we would move on to our next call. That's basically how it works on the PRU.
So we were relaunched, as I said, back in autumn of last year. We had a grant of just under 300,000 from Tower Hamlets Together, including 60,000 from LAS. And with that, we were able to launch our 12-hour-a-day service and explore further possibilities. Now, the advantage in expanding this after the launch is that we got more known. And one of the most fruitful responses that we've had is for the London Ambulance Service to actually call us into cases more and more. And these are cases that normally would have stayed in the community, would have actually been admitted to hospital. So London Ambulance crews already have a really keen idea of what's possible. They see what happens to patients in terms of they go there, they're in this environment, they're taken to hospital, and they can see that actually that didn't need to happen in a number of cases. So they call us in, and that's where we make a difference.
And I think what's really special for me, as I touched on it earlier, is actually the consultation. It sounds a bit old-fashioned, sometimes people think it's a bit woolly, but for me it's actually probably the most powerful thing that we do, is that too often when I'm in A&E reg, I'm coordinating an area of a department where there's a whole load of patients, and actually we're just juggling balls, keeping things safe, and that's what we do in A&E all the time, and front-load investigations, have interesting conversations with referrals occasionally, but actually when we're on the PRU, we have time, are not bound by time, and we are able to put the patient right at the centre of what we're doing and absolutely understand why they've called 999 and be undistracted from that. As I said earlier, I think it's really important, and I didn't realise the importance of this until doing this fellowship, is that actually seeing patients that haven't been medicalised gives you more information than you can ever hope for. So seeing an elderly patient who we've been asked to see because they've had a general decline for 2 months and the ambulance crew want to take them in, actually seeing them operate and function in their own home is more powerful than seeing them walk up and down a 2A corridor. And actually working out whether they can still make a cup of tea or walk up and down their own stairs, or see whether there's trip hazards that we can quickly get rid of, seeing them before they're in a gown, lying in a bed, looking like a sick person, we can intervene prior to that. And we're lucky because we see people in their own environment. We also see the networks they have around them. So we go into communities in East London that are incredibly deprived, which we'll talk about in a minute. But I've been into those communities and seen the most amazing community, and neighbours coming into the people's rooms, making sure that there's support structures. So we can see patients and understand the support structure they have around them to know whether they're going to be safe to stay there, to see whether there's people looking out for them. See their own function, and also see whether they're actually safe to continue their care, if appropriate, in the community. Or not always possible.
I think this is the nub of it. I can't actually oversee of injecting time back into the consultation. So what we've seen, I would say, over the past, I would have to say 20 years really, but it certainly has picked up speed in the last 10 years, is a whittling away of what I would call quality communication with patients in an appropriate environment, and that's been replaced by risk averseness and replacing a sort of a risk assessment that is jointly done with the patient and the doctor by tests and one review after another, possibly then followed by an admission for several days because there just wasn't the space to do it. And remember, I do work in A&E as well as in general practice. So I'm excited about this because I think we've seen something that's kind of getting worse and worse outside. And as we try to jump through hoops and hit targets, patients know, actually, you get good care if you go to X, Y, and Z, and it's making it worse for us in ED and in hospital in general. This reverses the trend. And as we go on through the rest of the slides, you'll see that, yes, there is a time commitment, but in terms of the value for money and in terms of managing risk, which is the thing that I think we're beginning to lose, it has a very dramatic effect.
And just, I'm sure you all know this, but to give you an idea of the environment that our patients come from here at the Royal London, we see patients in these sorts of estates on a daily basis. And we go up tower blocks like this that have broken lifts that don't get replaced in Hackney all the time, and moving patients that are sick up and down. This is difficult. But we have huge contrasts in our community as well. We're seeing patients in incredibly well-off areas of Islington that still feed into our hospitals, I've done a cardiac arrest up the Canary Wharf, and having a view of some of the places we do is just something that's just can be a bit of an overload with respect to everything that you're seeing around you. So we see some pretty amazing environments. We also see people that are just out on the street, some people that are living out on the street, and some people that are just in park benches. I probably should have taken this out, because approaching a patient on the park bench now is probably quite dangerous given what's happened recently. However, we do see patients that have hugely challenging social needs, and understanding how we can help them, and linking them into social homeless services around, and taking them to GPs that are able to accept homeless people, and linking them into those services is incredibly powerful for those individuals. But we do work in some pretty dangerous environments as well. In dark places, we go to some pretty violent crime as well, occasionally, albeit less than our trauma team colleagues. But just having that awareness that it's not always as safe as security being one call away to get help, and police aren't always forthcoming. With respect to the equipment that we carry, we touched on it earlier, but just to pick up on a couple of things, we do go to some cardiac arrests to support ambulance crews, normally when the advanced paramedic practitioners are tied up at other major trauma or cardiac arrests, but we will go to them in North East London, and I've certainly been to a lot pre-hospitally, and we carry various devices that you may or may not be aware of that improves patients' outcomes, with mechanical CPR devices called the Autopulse, and impedance threshold device to drastically enhance negative pressure in the chest to try and get higher preloads and more coronary blood flow when these patients are in cardiac arrest, and an active compression decompression device. We carry all drugs that we would normally have available to us in an emergency department, including RSI drugs, sedation, cardiac arrest drugs, and a full array of medical emergency drugs for whatever presentation may be. But this is exciting, and some people think this is great, but actually what's probably more powerful for the patients is the more simple stuff. So the stuff that we can do point of care on. That we carry point of care blood tests, and we can do a VBG or a set of U&Es, and the results are there within 2 minutes, and we can print that out and leave it with the patient. We can do crews can't do urine dips, can't do pregnancy tests. So any female with an abdominal pain is coming to A&E to make sure she hasn't got an ectopic. But we can turn those sorts of patients around in their own community, and it takes 5-10 minutes. So it's just simple stuff. But probably the biggest innovation recently is that we now carry a laptop linked to Cerner Millennium, so we can access patient records sitting on their own sofa via a virtual secure network, and that we can link into clinic letters, that we can see the call from our care respiratory nurses the day before. We can access all the stuff that we'd normally access in hospital, and that's probably been the game changer with respect to ongoing complex case management in the community, I'd suggest. But the other big thing for us is this, Dave, and you were going to talk about this.
Yeah, so over the years we've produced a directory of services, and we found ourselves really coordinating things much more in the community. Again, this is something which traditionally you would have thought that general practice would be doing. They do, but we appear to be uniquely placed to inform the GP, inform the hospital, put them in touch with ambulatory care. There's the DVT clinic. We've got the backdoor numbers to all of the GP surgeries, although I've noticed that some of the GPs have stopped having backdoor numbers. But anyway, the FRT, the AAT, the Rapid Response Team, and AR Care. So I think one of the great values of the PERU is coordinating that care, and that's a really important part of managing the risk.
Yeah, absolutely. It's really important. Our care especially, we work really closely with, I find, and I've certainly seen a number of patients out in the community on BiPAP and CPAP machines that have malfunctioned in the community, and we're able to quickly see them get new machines put in place to keep those patients out of hospital that would otherwise come and clog up acute respiratory beds for quite a while. So we have quite good working relationships with them. With respect to the Rapid Response Team or the Rapid Response Community Services, we do work really closely with them, as I've already said, and I think it's important to say that actually some patients can't be kept in the community, even with some things that are going on, but what we can do for those patients is at the point putting the cannula in, we can take their blood bottles, so these patients come to hospital with Bart's Health blood bottles, blood's already taken and management started, and direct referrals to various specialties depending on what the issue is. So we can tend to skip out that middle 2, 3, 4, 5 hours sometimes before they get an A&E SHO registrar review depending on the time of day. With respect to the admission avoidance team, we work really closely with them, all part of RRT, and we work with them to help review patients for them in the community, but we can also access them and put in PT and OT reviews for social issues in the community pretty quickly to allow patients to stay at home. We also have access to the rapid response team and can get clinical reviews from nurses or repeat blood tests the following day, etc. Exactly as you would access from an acute medical take or from an A&E point of view. We also have the older person's rapid access clinic or frailty clinic that has undeclared DAO, and we work really closely with them, and we often see patients that are just not quite right in the community, patients that have declined over a period of time, like we see in hospital as well. But those patients are quite easy just to send into an acute hospital for a GP or for an ambulance service to try and get all that sorted out quickly. But actually, they're probably, a lot of the time, isn't an acute thing. If there is, they come into hospital. But a lot of the time there isn't, but they need a proper, holistic, multidisciplinary team approach, and we can get them in within a week or two into an older person's clinic, which is fantastic. You may or may not know something called MIDOS. MIDOS is a London-wide initiative done by London Ambulance Service to know what all of the local facilities and referral pathways are for ambulance crews, and we exist as one of those for ambulance crews to refer to us for North East London, and we also have access to this should we need to know where the nearest dentist is or something crazy. We can look it up very, very quickly. But as said, CERN has been a bit of a game changer. Coordinate My Care, you may or may not have heard of that, but we have access to that through the London Ambulance Service, and that enables us, when we're going to a particular address that has a flag on it, we know that that address has an advanced care plan in place, or that patient has a DNA CPR already in place, and so we can access Coordinate My Care for these patients. Exactly the same way that we get number key locks to get into patients' homes when they're frail and can't answer the door. The thing that we're working on at the moment, and which is about to happen, is we're not only going to have access to hospital records, but we're also about to have access to EMIS, so we can access GP appointments and information from the previous few months. What we're going to touch on now is what we've done in the first 6 months of the Physician Response Unit's relaunch. Okay, so up until March of this year. So September the 11th was the day that we launched, up until March the 11th, which is why these two columns at either side is not quite as high as it would be because they're part months, but we've seen 1,077 patients in 6 months, which is a decent number. It does only equate to, on average, about 6 patients a day, but that's not every day, because I've certainly had days in double figures, so it depends on which patients you see. Let's just think about where our patients are. So we're commissioned by a combination of funding, but the funding came from Tower Hamlets Together, so most of our work should be in Tower Hamlets, which it is 40%. But it's important to know that although they commission us, we are providing a primary response to London Ambulance Service, so we can be dispatched across the sectors within London Ambulance Service. So we do cross over into Hackney, we do go to Islington, we go to Newham. If it's a bad day, we go up to Waltham Forest, which is a long way to get home from, and we do cover the City of London a little bit as well. What I find really interesting is this slide on the right, actually, which is almost like a bimodal age distribution, and we see that we would expect our elderly patients to become sicker and require more need from a healthcare point of view. But we have this group here, us lot almost, 20s to 40s, that are calling 999 more often, and we're getting dispatched to these people more often. Maybe because there's a change in expectations in patients, possibly. Maybe there's a change in their threshold for calling emergency services. It's really interesting that they're the calls we get attached to. Probably, I think, looking at the cases, probably because we can turn a lot of these around pretty quickly and not require any further NHS resource, and a lot of the elderly ones because they are the seriously complex case management cases that we go to try and orchestrate their care in the community. This might mean nothing to you, and that's okay. This is something called LAS dispatch data with respect to ambulance response program. This thing is null and void, which is why there's two. This was halfway through our trial. The London Ambulance Service, or the whole of the country, switched over to something called ambulance response program. Category 1 being our most serious cases we go to. So if you go to a category 1 call, they're the sort of cardiac arrest, they're the life-threatening hemorrhages, they're the unconscious with abnormal breathing. So these are the most serious cases, patients calling 999. Category 2 are seriously unwell. They're people that are having MIs, that are having strokes, that are unconscious, but they're not requiring as quite a fast response as a Category 1 call. Category 3 patients are still unwell, but they're more urgent in emergency care as respect to that. Category 4 we don't go to many of because they tend to be healthcare and provider or practitioner related admissions to acute hospitals. So they are your non-urgent transport into a bed. So actually, additional LAS resources, a lot of the time we don't actually require any further LAS resource, so we are the only provider to that 999 call, and that's happened in 57% of cases. 43% we will either have further LAS resources there prior to we getting there because it's more serious, or because we're providing a crew request response, or we require an LAS team to transport a patient into an acute bed. But 74% are primary dispatch, and 26% we go and help crews on scenes. The next slide is just to give you an idea, is something called disposition. It's a term I don't particularly like of, disposing of patients, but it's a disposition is what the London Ambulance Service use, and we manage in community about 68%, which is about the opposite to what a normal ambulance crew would manage, and we have to send in 30% of patients into hospital, and we do have 2% of our patient cohort that don't come to hospital, and they get what we call PLE, to pronounce life extinct in the place that they've called, or someone else has called 999 from, and that is because of the number of cardiac arrests we go to. And most cardiac arrests, do not come anywhere near the hospital. So most cardiac arrests don't come anywhere near the hospital unless you get ROSC, and in this area most of those patients wouldn't be coming to the Royal London anyway, they'd be going straight to Barts. So yeah, it's interesting to know. Disposition by category. This is reassuring information that shows that the triage system when you call 999 does actually work. It shows that for category 1 calls we take most of them to hospital. Interestingly, we leave 24% of category 1 calls at home, so there is some over triage because they're not all cardiac arrests, or if they are, we shouldn't be discharging them at the scene. But interestingly, we manage in community more as the acuity of the call, the category goes up, which is reassuring, obviously. With respect to the impact, David, do you want to touch on the impact we're having?
Yes, in terms of the impact, I mean, a lot of this is going to be very obvious, but if we begin to chip away, as we have done, at the ones that are high users, you're going to see an impact in terms of ambulances being parked outside of the hospital. You're going to see, what's the next one?
Sorry.
No, that's fine. This is a common scene. I work at WIPS as well, and it's quite common to see this kind. I've seen both here and at WIPS, and we can make an impact on this. I mean, bearing in mind, you don't need to see that many patients to see an impact on these two things. We're hoping, we think that it'll actually make, well, we know it'll make an impact in terms of GP resources, seeing them being overstretched, and of course we don't see this. We don't have lots of empty beds. So we have a bed occupancy problem, and we only have to see, we'll come to the figures in a moment, we only have to reduce bed occupancy a small amount to make a huge difference to the way patients are actually dispatched or discharged. And as you can see from here in terms of the impact, then we're keeping some of the more complex patients in the community. This is where we've kind of pushed the boundaries back. As the months have gone by, we've been able to leave more and more complex patients in the community. We've been able to look at somebody who appears septic, who is dehydrated, who has been into hospital several times beforehand. We've been able to do we've been able to do the examination, stand back, look at the support in the community. We've been able to leave these patients at home and follow them up. And we've actually reduced the risk, we believe. We can't quantify that. That's a personal opinion. Sorry about that. But we believe we've reduced the risk. So, yeah.
Yeah, I think it's also worth noting, actually, for those of you that work on hospitals, I don't need to tell you that discharging patients from hospital can be pretty challenging sometimes. And actually, I think it's worth just remembering, having in the forefront of your mind, that actually the reality of that, and what that comes down to, is ambulances don't go to 999 calls, and that's where the bottleneck is. So if ambulances can't hand over here, and they're stuck like this, then when you hear an ambulance crew's radio and information coming through that radio, that is because they've got uncovered calls in the local area, and that they're trying to persuade crews to free themselves up as quickly as possible. And the system we work in, the bottleneck is seen in A&E. The problem isn't always A&E, and actually a lot of what we can do is facilitate this care in the community, and it will solve a lot of problems. The other impact, the thing that I find quite special and quite incredibly rewarding, is because some of these patients have such complex needs and such complex care, and we'll talk about some of the cases in a second, that actually orchestrating their care is actually a huge privilege, and breaking down barriers and getting teams to talk to each other. Really simple interventions can have a huge impact. With respect to people as well, it attracted me and other emergency medicine colleagues to this sort of job, and actually it retains us in a system because we know actually there is a way of making a difference, and there is a huge retention problem within emergency medicine, and this is one way of correcting that. We work really closely with London Ambulance Service, and actually we're providing some of their training ongoing with respect to no ambulance physician currently gets any formal training in how to assess a frail patient. So how can we expect these patients to stay at home when they're not empowered to do that? So we've been running frailty sessions with London Ambulance Service about what sort of things we can do and simple interventions we can provide. Let's look at the evaluation quickly of the service. I know we do need to crack on a little bit, but we've looked at this service evaluation with respect to various organisations. We have various acute stakeholders that all have different vested interests in us. But the patient information we reviewed was from the 11th of September to the 11th of March. These average costs are national costs taken from NHS reference data from 2015-2016. This is the cost of a patient being seen and treated and referred. This is a patient of coming into hospital. Before any hospital intervention, it's cost the healthcare economy £236. And every patient that then gets seen in A&E is £138. And actually from Bart's Health, this data, this figure of 550 is from the finance team here, and that's the average cost of a non-elected admitted inpatient. Each night a patient stays in hospital, so that's from them. When we extrapolate that over the 182 days, we think that we've saved LAS being dispatched on the 610 cases. I think a number of patients, as it says here, the team estimated that out of the 730, 547 would have otherwise been conveyed to the emergency department. So they're the patients that we've made an impact in. There's a number that LAS would not have bought, hence the discrepancy there, and we've been fair to LAS with that information. And therefore we can say here that there was an estimated reduction in 547 ambulances in that 6 months, which is 3 per day, which doesn't sound like a lot, but that's £130,000. When we think about then those patients coming into A&E, we've saved 547 ED attendances, and £138 per episode is 75,000 cost saving to the economy, to the healthcare economy. It might be lost income to Bart's Health, but the health economy overall, this money is saved. This activity helps to reduce the overcrowding seen in our emergency departments, and it also demonstrates that ambulance and ED staff that there are alternative care pathways that can be used. When we then think about the 119 patients that were managed in the community that we deemed as a team after reviewing these cases would have been admitted to hospital, we matched them to something called HES data, which is more hospital statistics that's based on the primary diagnosis on discharge letters, linking them to the average length of stay across the NHS in England, and we saved those 119 patients based on their discharge diagnosis in the community 831 beds. The finance director here has looked at this data and thinks we've hugely underestimated this data, but we have been very conservative for a reason, but still the cost of a non-elective inpatient bed per night at Barts is £550, and therefore that's almost £450,000. So we look at that, and the total cost saving is over £600,000 in 6 months. Yes, we've got costs incurred. There's £150,000 worth of costs incurred, but the net saving to the health economy is huge, and we summarise that as £512,000 in 6 months. And I've got no idea why it's just gone like that. So that's quite an interesting figure, and a figure we can talk about in a little bit more detail in a second. Patient voice. We're currently 10th in Barts Health out of 215 services. The patients are highly recommending us with an average score of 4.9. There are various patient stories. We get patient stories about everything, and this is a very busy slide, but I'm just going to read out a couple of things that patients have said. They came to help me straight away and leave me at home. I was hit by a cyclist when I was walking through London and cut my hand open. The team arrived, commandeered a nearby pharmacy and sutured my wound and closed it within 30 minutes, preventing a hospital attendance in A&E. The next slide is more, I'm not going to read them all out, but providing a full assessment. The fact that an A&E doctor was sent out is fabulous. It saved me a needless trip to hospital and saved the hospital a lot of time. It was a very friendly service and made me feel very comfortable throughout. So we are getting positive stories, and we're making an impact on individual lives in East London. But let's just think about a couple of those stories. We'll probably just do two of these, David, but why don't you do that?
Yeah, so we went to a 90-year-old lady. The complaint came down as a funny turn in a nursing home. She'd fallen, hit her head, and had a laceration. So if we go down the right-hand side, which would have been the normal response, there would have been an LAS ambulance plus or minus an FRU. There'd have been a full assessment with an ECG, but she would have actually been sent to the emergency department, where another full assessment would have been taken, and possibly other investigations. The patient would then have been transported to the nursing home either that day or the next day, but there are things conspiring against the discharge actually occurring on the same day. This particular patient, we went to see her, normal assessment, we did bloods there, we did urine analysis, and we closed the wound. And the patient was left in the nursing home with support and with follow-up. There was a discharge letter to the GP, and the GP was contacted and informed of the need to actually follow this patient up.
So really simple things that these patients present to A&Es all the time, and they can be turned around and kept at home so they don't get confused and agitated in the emergency department, and really kept in a much better place. Let's just talk about this one here. I went to this case a couple of weeks ago with one of our one of the HEMS consultants, Gareth Davis, who was out with me. We went to a 45-year-old lady who was bariatric. She was over 150 kilos. She has multiple sclerosis. She's completely bedbound and 100% care dependent, and she requires, because she's so big, she requires ongoing CPAP at home that she uses for over 16 hours a day. That morning, she had an acute behavioural change that her family that she lives with recognised as quite a normal thing for her when she gets her recurrent UTIs. She has a catheter in situ. The LES crew, this was up in Islington, the LES crew wanted to take this patient into hospital, where the family tells us she normally has a between 5 and 7 day admission, and there's always a couple of days when they're waiting for the bariatric ambulance to take her home again, because it never quite makes it to the hospital to take her home, which I can completely believe. So actually, they called the emergency operations centre to say this patient needs to go to hospital, and that we need a bariatric ambulance, because some patients are too big to fit in normal ambulances. We only in London, inside the M25, there are 2 bariatric ambulances. Only 2 that have to provide all bariatric support. And there was between a 4 and 5 hour delay before the bariatric ambulance could come to this patient. And that's a private provided service through LES, and that's the way it works currently. So we got dispatched just to see whether there was a way of doing this slightly differently, because we have some quite good dispatchers in our emergency operations centre, and we went to this patient. We did normal observations, we did some point of care blood tests, so a normal set of U's and E's. We facilitated catheter change with the district nurses who came around and helped us, because we needed a number of people to do that because of her size, and we enabled community treatment for her UTI with a stat dose of IV antibiotics and ongoing oral antibiotics. Slightly different to the way that's done normally, but not only did it prevent a number of LES resources, including the hazardous areas response team, to lift someone over 150 kilos. It prevented a bariatric ambulance and probably a prolonged period of stay, and then quite a complex discharge just to restart all of her care. And actually, there is a way of doing things differently for this patient, and this patient stayed at home and had a great outcome, and wanted us to talk about her. So I said we definitely would. The PRU itself, I think, provides a bit of a paradigm shift, and actually a lot of the time ED is a bit of an island on its own within the hospital. But actually, when we take, in my job, when I take the learning that I've got in emergency medicine training out into the community, and then when I bring what I've learned out in the community back into the ED here, we learn an awful lot. And actually, I think there's something about the anti-medicalisation of patients that we see on the PRU, like I've already talked about, and I think that's really important, because sometimes actually the most important thing for some of the patients we see is about preserving their independence. It's about actually, yeah, they're not well, they might even be dying, but the last thing they want to do is to go into hospital. And ambulances really struggle to keep those patients out of hours and at weekends in the community because of issues in the community. I think it's really important that we are now starting to establish a system where we properly understand patients when we see them on the PRU. And actually, we not only become an advocate for them medically, we actually are in quite a unique position, quite a pure experience actually, to be absolutely their advocate socially as well. And I think that is quite powerful for us.
I think the other thing is that, I mean, we didn't mention palliative care. Palliative care illustrates this beautifully. So I want to state, because I know we're being recorded, I know that palliative care patients are being looked after incredibly well by GP colleagues in the community, but you only need a few of those patients to go wrong, or a few that seem to fall through the system. And we've been going to a few of those, and very often those are admitted with their complications, and it's quite difficult to coordinate everything. You certainly can't do it there and then in the emergency department. Going into a palliative care situation, giving a patient upwards of an hour's time, you cut through a huge amount. So you can coordinate various services. You can often deal with some of the fears that the patient is actually facing in the home environment. The most important thing is you keep the patient involved. So I think we've all seen this. As soon as they walk through the front door, not only does the hospital feel as if they are completely responsible for the patient, you couldn't possibly send them away without making sure that you've dotted all the I's and crossed all the T's. But the patient almost relaxes back and says, right, I'm now going to be looked after. Going to them in their home, you can use various ways, but basically you don't take that away from them. They remain engaged, and that's the most powerful and effective tool I think that we have access to. It's just there.
And we do what it says there. You know, we provide up-to-date knowledge, but we absolutely empower our patients to make the decisions they want to make. Too often we put patients onto pathways and they continue on that pathway until they get to the end of that pathway. But actually sometimes we can stop patients jumping on pathways, and that's really powerful when we do that properly. The next step for the PRU is we're at the moment going through a recommissioning process because our pilot was a one-year pilot, and we're working with our stakeholder providers to enable that to happen. We are also possibly looking at thinking about extended hours, although we're 12 hours a day, 365 days a year at the moment. There's increased workload into the late hours, into the late evening that we could certainly have impact on. Possibly thinking about extending our fellowships. I know Tony Joy, our clinical lead, is certainly with yourself as well, talking about getting some GPs and some geriatricians out on our car because they have certainly found observerships very useful. Maybe thinking about priority dispatch, which I'll talk about in a second before we finish, and also thinking about our Bart's Health footprint and working more with our colleagues at Whipps Cross and Newham going forward. Identifying high-risk patients, so that's what I mean by priority dispatch. Just to put this into context, a bit of work was done recently by the North East London Commissioning Support Unit by some very technical people that understand very complex mathematics that I cannot do. I can hardly use anything on Cerner, but they managed to get all sorts of statistics out. And interestingly, there's 224 patients at highest risk of hospital admissions. I don't know whether any of you know this here at the Royal London. And over 12 months, those 224 patients required 1,341 LES conveyances. They in themselves had 1,800 ED attendances, and those 224 patients in 12 months took up 10,000 bed spaces in this hospital alone. That's 224 people. So we're working really closely with the London Ambulance Service to try and flag these patients and go and see them as a priority, to try and keep some of these patients in the community to prevent them coming in. There are some of these patients that are hugely complex and will still come in, but even if we made a 1% reduction on that figure, it would be huge overall. With respect to what we're doing, as said right at the start by yourself, we have been featured in the Evening Standard and also on the 6 o'clock and 10 o'clock BBC News. We have won an EMTA award, Emergency Medicine Training Association, for the innovation of the PRU. We've been shortlisted and commended by the Health Business Awards at the House of Parliament. And probably the most thing that we're all, as part of our team, are proud of is that we've been asked to and now shortlisted for a HSJ award and a BMJ award this year for Emergency Team of the Year and BMJ, and shortlisted for Emergency and Urgent Care Trauma Care category at the HSJ Value Awards, which are really exciting, and it shows that there is clearly scope for this to carry on and for it probably to expand at some pace over the next few years. Thank you for listening. I'm sorry for taking up your time, and we've got a little bit of time for questions. I don't know whether you want to.